Hello ladies and gentlemen, I'm Stewart Bishop. I'll be your tutor for this session of Pathophysiology. This is Unit 3, the Neurological System by Professor Sue Washburn and Professor Tony Anno. Historically, I've done these tutorials live on campus, but I've found in the past that it's getting progressively more and more difficult to find one time of the week that's going to fit everybody's schedule. So I've decided this semester to try and experiment with some of the online tools, so we will be doing these hopefully live, but then also recorded as we're going to do them today, and just see how that goes and see if this doesn't give more people more access to the information at a time that's useful for you. I have in mind to have this accessible both on Dropbox and on YouTube. So hopefully they'll be uploaded later on today, so you'll have them for this evening to study for your test tomorrow. We will be using as our references, of course, the Pathophysiology book by McCants. I'm going to point out a few of the key parts of that book that I think are really useful for you. I also have some drawings of my own that I think can really help orient you, and we'll get into that in a moment. And then also, of course, maybe the most important thing is the actual PowerPoint for the course. So if you'll just follow along, I would strongly advise that you have your book ready and you have your PowerPoints up so you can follow with me slide by slide. I'm going to turn the camera now towards the screen so I'll be out of view, and but obviously you'll hear my voice, and I'll be pointing to the slides on the PowerPoint as we talk about them. Okay, let's reposition the camera and get going here. There we have it. Looks like a good shot. So go ahead and get your PowerPoints out and just follow along with me. Now, ladies and gentlemen, the first thing I like to do whenever I start the study of any pathophysiology topic is I like to start with a basic orientation to the anatomy of that system. In this case, we're looking at the anatomy of the neurological system. If we were studying the GI tract, for example, diseases of the GI system, we would be looking at models of the stomach and the intestines and the pancreas and the liver and so forth. But in this case, we're studying the neurological system, so let's start with a basic understanding. And when you think about neurological system, what comes to mind but a nerve? And it's really critical, ladies and gentlemen, to understand the basic structure and function of a neuron, which is the fundamental cell of the neurological system. So just take a minute to refresh yourself. You can use my drawing here, and/or when we go through the books, you'll see this similar type of drawing everywhere. But your basic components of a nerve include, remember that nerves synapse, they connect to one another. Here's a nerve terminal on the far left, synapsing with the dendrite of a second nerve. And then of course we have the structure of that nerve, and down here this nerve synapses with a muscle cell. And of course when the signal is sent, the muscle will contract, and you will have activity. Now, let's review the components of this in a little greater detail, and then this will help us as we talk about the diseases of the neurological system. You have one nerve here. This will be nerve 1. This is the terminal, or the end of that nerve. And in that terminal you have what are called vesicles, and they are filled with neurotransmitters. In this case, the neurotransmitter is ACH, or acetylcholine. It could also, other nerves have dopamine, serotonin, GABA, glutamate, norepinephrine, probably a few that have yet to be discovered. But when that neurotransmitter is released across the synapse, if enough of it is released, it will bind to a receptor on the dendrite of the adjacent nerve, And if there's enough built up there, it will start what's called an action potential. And that's this electric activity. And I'm sure you're familiar with action potentials as you go back over and remember your anatomy and physiology. This is just an electrical impulse. And the basic idea is that sodium rushes in and eventually potassium rushes out, and you get a depolarization, and it's an electrical signal. But before we get to that, let's just starting again with the dendrites. We have the dendrites which receive the signal. Here is the cell body. That's this large area here with the nucleus of the neuron right in the center of that. And then this long arm of the neuron is called an axon, okay? And at the end of the axon you have a terminal where you have these vesicles of neurotransmitters standing by. So we have a signal from one nerve to the next. It's powerful enough, it binds to that receptor in the dendrite. The dendrite receives the signal. This propagates a action potential down the axon, and when that action potential gets to the terminal of this nerve, it will release whatever the neurotransmitter is that will jump a synapse, and in this case it will synapse with a muscle, not another nerve but with a muscle, and that muscle will contract. You'll notice that there are these little boxes here. These are receptors for the neurotransmitter. So in a healthy person, the acetylcholine will lock itself into that receptor and the muscle will twitch. That's the whole idea of it. The other thing I want to point out, ladies and gentlemen, is this green material along the axon. This is a protective material known as myelin, and this is kind of like the insulin or the insulation on a power cord. So, and you'll also notice that there are little gaps in the myelin, and these are called the nodes of Ranvier. And the nerve is really efficient because the action potential, as it comes down here, only has to fire at these gap points. It doesn't have to fire all the way down the axon. So it's a very efficient mechanism. Okay, with that in mind, I also want to turn to our McCants book, and I want to point out just a few of the slides in McCants. Boy, I tell you, if you lift this thing, you won't have to go to the gym. You can just sit and lift your nursing textbooks, and you'll be built like Arnold Schwarzenegger, I'll tell you. Okay, so let's go to chapter 14. And I have a book that's a couple years old, but I think it's probably very similar to yours, and you have similar diagrams. You'll notice here, if you open to the start of your chapter 14, you'll see other diagrams of exactly what I showed you, which are the dendrites, the cell body, the axon. You'll see that myelin insulation and those gaps in there. And down at the end, you'll see a synaptic situation where this nerve will synapse with either another nerve or with a muscle. And nerves actually come in various sizes and shapes, ladies and gentlemen. They're not all that classic model that I showed you. Sometimes the cell body is in the middle of the nerve, sometimes it's at the end. There's different sizes and shapes to fit different purposes. Now here's a really great model. It goes into a little bit of detail, but it shows you, again, here's the axon, there's the terminal, and in this case here is a muscle, okay? This shows you how these vesicles open up, and the material in the vessel, the neurotransmitter, goes across the synapse and connects to receptors on the other side. And you may hear reference to something called presynaptic and postsynaptic, and all that means is this is the synapse, so this is the presynaptic side, and that's the postsynaptic side. It's really very simple. But that again shows you that, and of course we don't need this level of detail to get an idea of what's going on here. But it's good to have the basic big picture. Now, another slide that I think is very, very useful is this one here, which shows the reticular activating system. You can see that reticular activating system, and this is a critical part of the mid and lower brain stem. It involves all these areas. And together these areas are called a system. And it's this system that allows us to maintain consciousness. And when this system is disturbed, we can lose consciousness. Very, very important that the RAS system is part of and we'll go into greater detail on that in just a moment. But I'm just trying to orient you to a few really important parts of the body. Now, another thing here on this other side, we're jumping ahead to the endocrine system here. But look at the very middle of the brain, and you'll see an area called the hypothalamus. And right below that, you see this little thing that looks like a couple of peas hanging down. That's the anterior and posterior pituitary gland. And you'll see that's right in the middle of the brain, and an extremely important area for control of the endocrine system, and also control of what's known as the autonomic nervous system, or the automatic nerve system. I mean, everything in this chapter is fantastic. I'm just trying to point out a few of the things that really help you orient. And I like to do that. Like I said, I like to kind of orient to the basic anatomy of the subject before we start delving into all the details. Now, again, here is another example of a nerve. There's the axon coming down. Here is the terminal of that. And then here is a muscle fiber, or a muscle cell, and you'll notice that there's again the synapse and the neurotransmitters going across that synapse, and when they hit that muscle in a healthy person, the muscle will contract. But you can have diseases, ladies and gentlemen, and I hope you're starting to think already. Where might I have a disease? And the answer is anywhere. You can have loss of myelin, as you do, for example, in Guillain-Barré, or in multiple sclerosis, where the myelin is lost. And you can imagine if you lose your myelin, your action potential won't be effective. So the muscle, the nerve and the muscle will be very weak. And also that would expose the nerve to the interstitial fluid, and that would be very inflammatory, and it could cause death of that nerve. You could also have a disease of your neurotransmitters, where all these neurotransmitters have a compound, an enzyme that will break them down and send them back into the terminal. Well, if you can imagine if there was something blocking these receptors here, the neurotransmitter would come out and it would try to connect, but those receptors would be blocked. Meanwhile, the enzyme would come in and break them down before they've had a chance to work. So you could have an error in that area. You could have trauma to the nerve, such as you would have in a concussion. You could have a flood of blood all over it, as you would have in a hemorrhagic stroke. Or you could have a deprivation of oxygen, as you would have in an ischemic stroke. Another thing you could have a derangement of the electrolytes. So maybe you don't have enough sodium, or you have too much sodium. So your action potential isn't going to be good. So there are all sorts of potential causes of disease on the nervous system. Okay, going back to McCants here real quickly, just to highlight a couple of other really important topics for you. And of course, we're going to go over the PowerPoint, and all these topics are contained in the PowerPoint also. Jumping over here to chapter 15. There's a very important slide here. It's a table, and it shows you the levels of acute coma. And notice that these are kind of the levels of deterioration if somebody starts losing consciousness. So we would start out at the top, what's called alert and oriented. And if your consciousness begins to decline, you first become confused. And then if it gets worse, you become disoriented. Worse, you are lethargic. Worse still, you're obturated, then you're stuporous, and then you're in a coma, a light coma, and a deep coma. So these are levels of deterioration of consciousness. It's really important for you to become aware of those. Also, there's some important forms of breathing that are associated with these deeper levels. You really want to study what happens to the rate of breathing and what drives it. For example, Cheyne-Stokes breathing is oftentimes driven by the hypercapnic drive, or the accumulation of too much CO2. Normally we have a hypercapnic drive, but we also have a hypoxic drive. But in this derangement, it focuses more on the hypercapnic. And again, we'll get into that in just as we go through the PowerPoint. But I just wanted to give you a little orientation, ladies and gentlemen, before we jump into the PowerPoint. Now, let me just double check make sure we've got a good image here. Great image on the camera. Okay, we'll start right away here. Of course, again, this is Unit 3. And we're talking about alterations in the cognitive system. So that's what a pathology is. A pathology is nothing but an alteration of a normal state. Now, consciousness has two parts: arousal, the capacity to be woken up and the capacity to become alert, and also awareness. Once I'm aroused, I'm aware of what's going on. Those two things are required for consciousness. Now, arousal, notice that the cognitive cerebral functions cannot occur without a functioning RAS, or reticular activating system, like we talked about. That is a key part of the brain that's involved in consciousness. Now, what are some of the things that will alter our capacity to be aroused? Well, some of the causes are infections. You can imagine encephalitis or meningitis. If you had that on your brain, it would really destroy the neurons. If you had those pathogens and inflammation going on all over the neuron, you can imagine that it would the brain would completely lose its capacity, or largely lose its capacity to function, as long as that serious active infection and inflammation was going on. Vascular would be either too little blood, as in an ischemic stroke, or too much blood, as in a hemorrhagic stroke. Neoplastic, of course, is cancer. Trauma would be a concussion or a penetrating injury, or what we call traumatic brain injury, TBI. Congenital, you could actually be born with something that would alter your arousal. And that effect could be immediate from birth, or it could take place later. For example, in the case of Huntington's disease, which is a certain genetic event, but it usually doesn't occur right at birth. You could have degenerative, such as with dementia, or Alzheimer's, or with alcohol dementia, for example. Or it could be polygenic, could have a number of causes. It can also be metabolic. It can be related to too much glucose, too little glucose, too much sodium, too little sodium, too much potassium, too little potassium. All those factors that go into the normal metabolism of the cell, if any of those is off, you could have a disease that arises from that. Also, you could have psychogenic. This is where a patient is so consumed by their mental illness that they start acting in really crazy ways. And we know that, for example, somebody that is highly manic has a tendency to have a very high level of epinephrine, and this can really cause an imbalance in their natural neurotransmitter balances. So it can be also your arousal and awareness can also be changed internally by your mental state. Okay, now this is just some more details about some of the changes in metabolism. We've talked about those. Hypoxia, obviously shortage of oxygen. Electrolyte disturbances, that could be a change in sodium, potassium, calcium, any of those key electrolytes involved in action potentials. Hypoglycemia, which would be low blood glucose, and so on and so forth. And also notice that origin of the problem doesn't necessarily have to be in the nervous system. The origin could be here in end-stage renal disease. If you had a poorly functioning kidneys, you would have that in itself would give you electrolyte disturbances, and it might give you a pH disturbance. And so a disorder in the renal system or in the liver system could in turn create conditions that would support a neurological disease. Okay, alterations in arousal. These are some of the changes that we see when somebody has a change in arousal. Their LOC, or level of consciousness, is going to change. So for example, let's say that I know you very well, your name is Mary, and I say, "Hi Mary," and I don't get a response. You're staring blankly at me. Well, there's a change in your consciousness. Now maybe there's no other change. Maybe your heart rate is still okay, your vital signs, your oxygen saturation, but I'm starting to see a change in your level of consciousness. This is one of the first indicators that one of the first overt indicators that something is wrong with a patient with their neural system. So you always want to respect a change in level of consciousness. You could also have those Cheyne-Stokes respirations, and just the pattern of breathing in itself. When somebody is alert and oriented ×4 and the brain is properly functioning, the brain is controlled by breathing is controlled by the autonomic system, which in turn is controlled by the brain. And the brain does that for you. You don't have to set your respiration rate. The brain will do that automatically. But in a brain that is diseased, those respiration sensors will be off. That they won't be able to properly detect levels of oxygen, levels of CO2. And you'll begin to get irregular breathing patterns. You need to study that. And of course, like we talked about, Cheyne-Stokes is kind of one of those really serious indications that there's a change in consciousness, and that's oftentimes driven by increasing levels of CO2. Pupillary reactions. Your pupils will either go to a pinpoint, or they will open very wide, or they will become fixed, and they won't fluctuate in response to changes in the levels of light. Oculomotor. Those are the nerves and the muscles that control the movement of the eyes, and that you test that in assessment with the 6 directions, the 6 cardinal directions of eye movement. And in somebody that's having a really bad brain disorder, they're not going to be able to properly move their eyes. And the reason for that is very simple, that cranial nerve 2 and 3, the optic and the oculomotor, and cranial nerve 4, or cranial nerve 6, the abducens nerve, those all control the small muscles around the eyes. Well, those nerves come right off the brain. So if there's an injury to the brain, those eyes are not going to be able to move properly. And last but not least, motor responses. That's simply the ability to voluntarily move your hands or your eyes or your arm. Those responses will start to slip away as a person gets deeper into loss of consciousness. Okay, now clinical manifestations. That's just a fancy term for what will you see in the clinic. When the patient comes to you in an outpatient office or in the hospital, what manifestations or symptoms are you going to see? And again, the level of consciousness is going to be that most important indicator that something's wrong. Now, when the patient is very alert and very healthy, we say that they are alert and oriented to four things: to themselves, to others, to where they are, and to the time. So you can ask them, "What's your name, please, and your date of birth? Can you tell me where we are? Can you tell me why we're here? And if there's somebody else around them, who's with you today? And also, do you know what time of day it is, or the month of the year?" They should be able to identify all that. Also, with others, they should be able to identify a notable person, like who is the president. If a person can do all of that, we say that they're alert and oriented ×4. Now that's the high normal alert and oriented state, but what happens if they start falling down? Remember I showed you out of McCants those levels. First you start alert and oriented, then you go to confused, then you go to disoriented, then you go to lethargic, and down the line. It just gets progressively worse. And let's look at each one of those a little bit. Confusion, that's the first one, where you're not able to think as rapidly and clearly as you might like, and your judgment's a little off. But other than that, you are alert. But now you start to get disoriented to where you don't even exactly know where you are. And you're starting to lose your memory. Your memory is starting to fade a little bit. You can't remember faces and the like. And then the last thing to go is recognition of yourself. You even forget your own name. Now, if it gets worse than that, you get into what's called a lethargic state. Now, lethargy means that you're kind of in limbo between being alert and being in early stages of a coma, okay, where it's easy to wake you up. I can easily wake you up, but when I do, you really don't know where you are. So it's kind of that limbo state. Now, if it goes deeper, you get into something called obtundation, where you're really spending most of your time unconscious. But if I just stir you mildly, you will come back, but if I don't keep stirring you, you're going to go right back to being obtudated, to losing your consciousness. Now, if it gets worse than that, you get into stupor, which is you will only become conscious after a very deep shaking, and it might be just to open your eyes. That's just about it. But if you can't even do that, then you lapse into coma, where you just do not have any consciousness at all. Now, hopefully that's a transitory situation and you'll come out of the coma, but sometimes people don't, unfortunately. But that is a condition of complete unconsciousness. Now, I would like you to make sure you study your patterns of breathing and what drives each one of these types of breathing. You will see these types of breathing in different, and notice they are driven off of different levels of the mid and lower brainstem. I believe that's the pons area. That has a lot to do with the autonomic control, the auto control of breathing. And you have receptors in there that will receive information about levels of oxygen, levels of CO2, and if the CO2 builds up, then it's going to give you more breathing, or if the O2 goes down, it will give you more respiration. Pupillary reactions, you can read about this, where the pupils will become fixed, small, large, and other derangements of the pupils. And notice again, that's being driven by injuries to different parts of the brain. So you're going to have, and this can give us a clue as to what part of the brain is injured based on how the pupils are responding. There are also motor responses to the body. The top one is called decorticate, and this is a loss of the cortex. Now the next one is decerebrate, where you have the hands rotated in an abducting type direction. Here you have them adducted into the back into the chest, and then here you have a mixed picture, adducted on one and sort of rotated outward and extended on the left arm, and you can see that this very well could be due to two separate lesions in two separate parts of the brain. Now, what are the outcomes? If somebody has a very severe case, we can have either what's known as brain death or cerebral death. Okay, now brain death, as you will see, is death of the entire brain organism, the entire brain organ system, whereas cerebral death is death only of the higher areas. And if you can imagine, if the higher areas die but the mid and lower areas remain, we could still see a patient that is breathing, even though they really don't have capacity to think because the higher brain has been killed, or the cerebral area has been killed. The lower areas that operate our breathing and our heart basically may still function up to a point. And we'll get into that in just a moment. So here's brain death, which is total brain death. The entire brain has been destroyed, including the upper, the middle brain, and the lower brain stem. So with that, the brain really cannot receive any information about how the body is doing in terms of breathing, in terms of heart rate. And you can see the criteria. You can read those on your own. Now contrast that to cerebral death, which is an irreversible coma. The patient is not going to come out and gain any meaningful consciousness, but the brain stem and the cerebellum will remain intact. Those areas of the lower and midbrain, they will remain intact, so they can still maybe run the lungs, run the heart, but you will not get that upper brain activity associated with thinking and fine touch, fine motor skills, etc. That's all gone. So even if somebody survives this, they would remain in coma in what we call a persistent vegetative state. Okay, in persistent vegetative state, that's described in the next slide here. So ladies and gentlemen, I think you can see at this point, let's just pause for a moment. We're a little less than halfway through this PowerPoint, and I hope you see that one slide builds on the other. We started out with a very simple understanding of what the neuron is. We looked through a few key slides to identify where the reticular activating system is and a few other landmarks in the brain. And we started out with an understanding of what those levels of consciousness are. And I think you can see as we go slide by slide by slide, it's very easy. Each slide is going to build on the one before. And if you ever get lost, the thing to do is go back a couple of slides until you get to a slide where oh yeah, I know that, I'm solidly, that's my foundation, and then just go back and restudy the slides that come after that, and you'll be fine. Okay, now, this is just a learning check. A 20-year-old male suffers a severe closed head injury in a motor vehicle accident. He remains in a vegetative state 1 month after the accident. Which of the following structures is most likely keeping him in a vegetative state? And the answer to that, ladies and gentlemen, well, he has a vegetative state, so we know that he has cerebral death, correct? So it wouldn't be the cerebral cortex. The spinal cord, of course, that's lower down. It's important, but it controls lower level functioning. The cerebellum, of course, again, very, very important, but that's in the back of the brain, and that kind of controls gait and integration of messaging. So the answer is probably brainstem, because that's where you have those autonomic functions of control of respiration, control of heart rate, and so forth. Seizure disorders. Okay, now seizure, ladies and gentlemen, keep in mind a seizure is simply, and this is why it's so important, here we are, right back to our little simple handout here. A seizure is nothing but uncontrolled electrical activity. So what happens in a seizure is we have this nerve sending a message to this nerve, and the message should stop. We should have one action potential, and then unless we need more signaling, that's going to be it. But in a seizure, it just keeps going and going